The question is, what does it do to their risk if they fail that treatment and need to have surgery? This is a study reported last year from the Mayo Clinic in which they looked at a series of consecutive patients with pouches, 47 of which had been treated with infliximab within the last 12 weeks and 254 without, and found that there were increased risks, pouch-specific complications, and overall infectious complications in the subgroup that had been treated with infliximab. And after a multivariate analysis, the only independent predictive factor was the infliximab. A similar, slightly different design study was recently published from the Cleveland Clinic. They took 46 two-stage pouch patients who had been treated with infliximab and matched them to 46 who had not been given infliximab, again within a 12-week period. And they also found a significant increase in the risk of sepsis and the risk of anastomotic leak. So here we are again, given pause about the patients who need an operation. Does this change the emerging consensus about pouches in the subset of patients treated with infliximab? Of course, nothing's completely crystal clear, and there is some data that suggests that there is no difference in complications. There's a study from Belgium that looked at patients, again, treated with infliximab and compared to those who did not, and they did not find any difference. A report from Mass General includes a much bigger group of patients, both Crohn's patients, ulcerative colitis, and patients with indeterminate colitis, and they also found no increase in the risk of complications. So I think the jury is still out about that, although the larger studies from the larger institutions are giving us all pause. So where we are in terms of ulcerative colitis is still that there's been almost near universal adoption of a J-pouch, near universal use of a double-stapled technique. We do a one-stage technique in very carefully selected patients, and laparoscopy is certainly gaining as a favorable operative technique for this. But in the subset of women of childbearing age, it certainly requires careful counseling about their fertility. Perhaps doing a fully laparoscopic procedure will protect them, but one which there's more data to support is that we do just a subtotal colectomy and stay out of the pelvis completely. And then all of us are considering what we should be doing in patients who have been recently on infliximab and whether they should always have just a subtotal colectomy with an ileostomy and a Hartmann as their first stage procedure. So then I'm going to move on to Crohn's colitis. There are a number of options for the surgical treatment of this, as you all know, and the questions involved in the decision-making are what are the recurrence rates and what is the quality of life. And the first one is a total proctocolectomy always necessary? And this is data from almost 20 years ago now that compared the recurrence rates depending on what type of operation patients had, either a right colectomy, abdominal colectomy, or total proctocolectomy. And obviously, this is a selected group because it's dependent on where their disease is located. But the lowest risk of recurrence was in the group that had a total proctocolectomy. More recent data also shows this, that although there are less striking differences, perhaps due to better medical management, but pretty safely, we can say that the patients who undergo a total proctocolectomy have the lowest recurrence rates. However, historically, that's meant permanent diversion. What is the risk in those patients of getting permanent diversion? This is a study that looked at the location of disease. Not surprisingly, if you have distal disease, you're more likely to get permanent diversion. But that risk is pretty high at 54%. And another group analyzed what are the particular risk factors for that. Women are more likely to need permanent diversion. Clearly, people with perianal disease are more likely, and those with left-sided colitis. So total proctocolectomy has the lowest recurrence rates. It's probably inevitable in some patients. The partial colectomy has a fairly high recurrence rate, but there is a substantial percentage of patients who can avoid a permanent stoma and presumably have an improved quality of life. But it raises the question, is an ileoanal reservoir a reasonable conclusion? Some would say even asking this question is sort of raising Mae West's point that we would choose the one we haven't tried. The interest came from a group in France that 31 patients with Crohn's colitis who were carefully selected, they did not have small bowel or perianal disease, underwent ileoanal reservoirs or J pouches. There was 20% had significant complications, and 2 of those required pouch excision. Another 2 had recurrence in the pouch but responded to azathioprine. So this is a bit of how you view the movie, but this group felt that that meant it was reasonable to do this operation. They then compared their patients with no ulcerative colitis who underwent a pouch procedure to patients with known Crohn's disease who underwent a pouch procedure. And at a 5-year follow-up, they found no difference in stool frequency, continence, leakage, use of protective pads, or sexual activity. They have updated that series with additional patients, and now in 100 patients, in a larger series with a mean follow-up of over 100 months, they have found that about a third of them have recurrent Crohn's disease, while only 10% have required excision of the pouch. There have been a number of other authors who've looked at this since that initial interest, and they're a relatively small series, but some of them have reasonable follow-up. And that in the range of failures varies quite a bit. It probably averages out at about 30%, but you can see that it ranges from 12% up to 60% of patients who had to have their pouch removed. This is a study from the Cleveland Clinic looking at their patients. This was just recently reported, looking at their patients with Crohn's disease who underwent a pouch procedure and compared them to the patients with ulcerative colitis or indeterminate colitis. So it's not a pure group of just ulcerative colitis patients, but certainly a large number. They also found that there was a significant difference in pouch failure, about 10-fold, that there was much more incidence of pouch fistulas. Pouchitis was about the same, strictures were about the same, and obstruction was about the same. But this clearly is a group that's at risk for failure of their pouch. The possible candidates are patients who do not have any perianal disease, they have no small active or history of small bowel disease, that they clearly understand what the risks are, and that they're highly motivated. But I think that maybe I certainly feel this, maybe the rest of us would agree that you'd perhaps be the surgeon but not choose to be the patient in that subset of patients. However, it is all a matter of perspective, and some people are really motivated to try an ileoanal reservoir. If we're not going to do that, or maybe they don't need a total protocolectomy, is a total abdominal colectomy preferable to a segmental colectomy? There's been a meta-analysis published about this as well, and this looks at studies from 1988 to 2002, looking at the endpoints of recurrence, morbidity, and permanent stomas. There were 6 studies that qualified in a pretty even split between abdominal colectomy and segmental colectomy. There was no difference in morbidity from the procedure. There was no significant difference in surgical or overall recurrence rates. There was a trend that if 2 or more segments had been involved with disease, there was a lower surgical recurrence rate with the ileorectal anastomosis. There was a difference in terms of time to recurrence, that the patients who had a segmental colectomy recurred sooner, and this was statistically significant. There was no difference in the rate of permanent stomas, and some suggestion that quality of life was better with a segmental colectomy.